just to let people know. So welcome everyone to a patient engagement workshop on preclinical lab research. My name is Dawn Richards, and I'm the patient engagement lead at the Brain Heart Interconnectome. And I am joined today by my colleague, Andrea Smith, and I'll just ask Andrea to introduce herself really quickly.
Hi, everybody. My name's Andrea. I work for the Brain Heart Interconnectome as the specialist in patient engagement and knowledge mobilization.
Thanks, Andrea. So today's workshop is a collaboration between the Patient Engagement Crosscutter at the Brain Heart Interconnectome, or BHI, and OPERA, the Office of Patient Engagement Research Activities at the Ottawa Hospital Research Institute. And we are joined by our colleagues from OPERA, along with a patient partner who will be co-leading the workshop together today. I'm going to let them introduce themselves because I know they'll do a much better job than I will of doing so. But really briefly, they've each shared with me something that they hope each of you takes away from the workshop today. So Susan is hoping that you'll take away that patient partners are useful as members of your research teams and that they can help you in many ways. And she prefers that you engage patient partners from the beginning of your work. Alicia challenges you and says that sometimes you need to be creative when you work with patient partners. And don't be afraid of that. There are lots of resources that can help you out. And Stuart hopes that following up on that, you take away that you know where to go for help in your patient engagement work, and you know how to reach out to, or you know who to reach out to. So our workshop today is an hour and a half. The first hour or so will be mostly some presentations and some conversation amongst our leads of the workshop. And if you can join us for the last half hour, that's your opportunity to ask any and all kinds of questions. And if you've got patient engagement plans that you'd like some help with, or you've got questions about that, we're all happy to help you out with that as well. So that said, I'm going to pass things off to our workshop co-leads, and I'll come on again at the end just to wrap things up. So over to you, Susan, Stuart, and Alicia.
Thank you. So I'm just going to start with a land acknowledgement because I'm based along with Alicia at the Ottawa Hospital Research Institute, which sits on the same site as the Ottawa Hospital. And so we respectfully acknowledge that this is located on traditional and unceded Algonquin territory. And we have the privilege and responsibility to serve First Nations, Métis, and Inuit, and to demonstrate respect for the contributions, culture, and traditional knowledge of all Indigenous peoples. And I think this is more than just a statement here. I think when we think about patient or community engagement in our clinical work, preclinical work, I think we have to recognize the history, the context, the trauma that might come with our requests, but also how that's being received by those individuals and communities. And it may be historic, it may be individual. And so I think we need to reflect on that as we reach out to patient partners and community members to engage with us and understand and think through how we can support those individuals and communities and work with them to build relationships, because this is undoubtedly relational work. Next slide, please.
You want to introduce yourself first, Stuart?
Okay, we'll go from right to left then. So I'm Stuart Nichols. I'm a scientist here at the Ottawa Hospital Research Institute, where I'm based in the what's called the Methodological and Implementation Research Program. And I have a particular program of research where I'm interested in how do we do patient engagement well? How do we evaluate this? How do we think about this? And how do we move this area forward. And that includes working in clinical research, but also thinking about how do we do this in other areas of research, including preclinical research. And you'll hear a little bit about some of the work I've been involved with later on. And I will pass it over to Susan.
Well, I'm Susan Wolf, and I'm the patient partner. That's my preferred term. And but other people prefer other terms, such as just advisor or person with lived experience. I came to doing this on the request of my husband before he died, and what he wanted was to make sure that things, the research was focused on patients and that the patients would be included and be able to contribute to your research.
Thanks, Susan. I'm Alicia. I also work with Stuart in the Office for Patient Engagement and Research Activities, and I had the pleasure of working with Susan on a recent project. And I'll tell you more about what the Office for Patient Engagement and Research Activities does near the end. So we kind of went over this already, so I'm going to quickly skip. So for today's session, we're hoping to give you a brief kind of understanding and description of what patient-oriented research and patient engagement is, talk about the foundational principles behind this work, and also explore some approaches to actually doing patient-oriented research in the preclinical space, and also talk about some of the appropriate resources and supports available to you. Andrea, could we do the poll?
Yeah, 1 second.
So we just have a quick poll to see who has heard of patient-oriented research or patient engagement. Okay. So I'm just going to end the poll. And it looks like majority of people here have heard of patient-oriented research or patient engagement, which I'm really happy to hear. And for the 2 no's, hopefully you'll be able to know what those terms are by the end of this session. Oh, I didn't share the results. Okay, now you can see the results. Okay. So what is patient-oriented research? It's a continuum of research that engages patients as partners and is very focused on patient-identified priorities, that is focused on improving patient outcomes. And on the right, you can see some methods that have been used to incorporate patients in the research process. For example, patient-oriented outcome measures, consensus methods like Delphi surveys, or qualitative methods where you do interviews or focus groups of patients. And patient engagement has lots of different definitions from different organizations, but the kind of common thread with all these definitions is that it's working collaboratively with patients. And so just a note on terminology, we're using patient engagement, but you may have also heard of patient and public involvement engagement, or even consumer engagement. And so just to really hammer it home, our focus is patients as partners. So they're part of the research team. We're not collecting data, so they're not participants, and they're not patients. And so we generally recommend not asking patients that you're actively providing treatment to be your partners, although there are some gray areas that we can talk about more. And just another note on terminology, and Susan mentioned this earlier, but it is a good practice to ask your patient partners what they would like to be called. And there's lots of different preferences that people may have. They may like to be called a patient advisor or a caregiver partner advisor, a person with lived and living experience, a community advisor or a peer advisor, consumer or user is also often used. So how is the term patient partner defined? So in this presentation, we will be using patient partner to be inclusive of both individuals with personal experience of a health issue, but also caregivers as well. I also wanted to mention where you can find patients or individuals with lived experience. You can find them through personal clinics if you are a clinician. You can also put posters in people's clinics, advocacy organizations, patient engagement offices such as Opera. And also wanted to mention that when you are finding patient partners, it's good practice to find at least two, making sure that you're not, and this is because one patient partner is often doesn't have an experience as representative of all patients. And so having two can help provide more opinions and experiences represented. And it also provides peer support for patient partners on your team. Susan, would you like to share a bit about how you would like to be called? Oh, Susan, you're muted. Susan, you're still muted.
I prefer the term patient partner because that's how I started with this work, because I was my husband with a team of nurses in Winnipeg, and it just kind of stuck. So I'm comfortable with it, but other people prefer other things. And I basically would respond to any of those terms, but my preference is patient partner.
So when you're doing patient engagement and patient-oriented research, one of the things is you want to be doing research, and when you're doing research for patients, you really want to be including them in the research process. Nothing about us without us goes into that. How if we're doing research for patients, they really should be included in terms of how you're doing the research and what are the purposes and outcomes that you're hoping to get out of the research process. So how does preclinical research fit into the scientific process? And it's good to go back to where it kind of fits into the whole research cycle. Oftentimes, we're doing preclinical research as kind of the basis for getting research that can inform clinical research in the future. And so even though you're working with animals or cells in a lab, the end goal ultimately is to improve patient care, which is why it is important to do patient engagement so that patients can inform the research that's being done at an earlier stage. And like Susan mentioned, you really want to be including them throughout the research process and also the research cycle as well. So patient engagement is increasingly common in clinical research, but there has been a slow movement to include more patient engagement in preclinical research. And so some of the common benefits of it is that there's better research quality, there's more diverse perspectives included in the research process. It's becoming a common funding requirement, and it encourages mutual learning between patients and also researchers. There's improved communication as well in terms of the dissemination of research after the dissemination of results after the research project, and also identifying unmet needs. And so patients can set those research priorities earlier and can also enhance the outcomes as patients are included in the outcome selection. And so there are some differences between preclinical patient engagement and clinical patient engagement. For example, the location. Oftentimes preclinical research, they're in these these locations such as labs that might require certain training to allow people to come into the labs. And so maybe you have to be creative in terms of how you actually engage patients. Language as well, there's often lots of clinical terms that may require you to be a little bit more creative and make sure that you are creating tools to help bridge the gap in terms of more academic speak into lay terms. And then backgrounds as well. Keeping in mind that all patient partners come from a scientific background, and having non-scientific backgrounds represented at the table can also create more diverse perspectives at the table. Training as well. And like I mentioned, Sometimes you may need training for the location and also having training in terms of how to do patient engagement and research as well, and some more kind of specific training to preclinical work as well. So why is patient engagement and preclinical research important? Like I mentioned, preclinical research is at the beginning of the research cycle, and so helping set those research priorities early can reduce research waste as research is translated into the different stages of clinical research. It can also increase public trust in research as it encourages mutual learning, and so that patients and members of the public are also able to learn about what happens before clinical research is done. And it also fosters bidirectional learning and research motivation as preclinical research, although you're not working with patients, having patient partners can help you remember that ultimately the goal is to improve patient care and see how your research is going to impact patients. So now I'm going to pass it to Susan to share a bit more about her journey with preclinical patient engagement.
My journey began with my husband having a stroke in 2019. And we were watching a German program on TV, and Ron had put the subtitles on for me. He was fluent in German, but my German was pretty rusty. I left the and went into the kitchen for just a moment. I came back, and Ron was slumped over a little, looking at the subtitles. And I knew immediately something was wrong. So I got a blood pressure machine, a thermometer, and a stethoscope, and called the ambulance. Then I took his vitals. They were perfect, they were textbook. Anyway, the paramedic supervisor and I finally agreed that Ron was having a stroke, and he was taken to the Civic, where he received the treatment he needed. The stroke was in the Broca's area of his brain, and it took almost a year, but Ron had a genius level IQ, and he was back reading and writing at a university level within the year. He did that. He achieved this because we worked really hard. Before Ron died, he asked me to continue working to make things better for stroke and glioblastoma patients. He knew this wasn't going to be easy for me because I don't like crowds and I find public speaking difficult, but I accepted his challenge. My first task was being Ron's advocate during his stroke and glioblastoma. Ron's wish was to die at home, and because his oncologist was on holidays, the other doctors refused to send him home. This was during COVID, and we lost 9 days. I wrote a letter to the hospital, and when asked what I wanted, I said that I wanted the doctors to listen to me and to other patient partners. The upshot was the patient partner program, where regardless of what's happening in the community, if the patient partner is willing to take any training needed, they will have access to their partner. My initial project was talking with nurses in Winnipeg, and that was very rewarding. But I've also worked on a variety of projects with the Ottawa Hospital, with Dr. Manjo Lau, and a stroke project on a stroke project, and with Opera. On the stroke project, I was a patient partner helping develop the scope of the research. I vetted documents and was a co-writer on the final document. I've also been involved in teaching students how to write suitable papers for the lay people. I'm also involved with a group of researchers across Canada in a project called iNeuron. I'm part of the ABLE group. The iNeuron project is looking at ways to convert astrocytes into neurons, and with ABLE, we teach the researchers how we can best keep them focused on what the patients need. Often individuals doing research don't think of the patients that their research is going to help. The most important thing to remember is that patients and their partners are not stupid. Many doctors and nurses have talked down to me, and this always results in poor communication and a lot of frustration for everybody. Had Ron stand-in doctors read his file, they would have known that he wanted to pass it home. I know that his oncologist had noted this in Ron's file. Instead, we missed the 9 days, which was heartbreaking. Your focus is on your research, but my focus is on the result and how your research is going to improve lives for patients. If you are doing research, the time to invite your patient partners is from the beginning. Okay. So what can we do for you? Patient partners can do a lot. First and foremost, we can help take your focus from just the lab and get you to look at the wider picture. It's just too easy to focus on one thing and have tunnel vision. It's harder to look at the bigger picture. And really, if you aren't thinking about patients, why are you even doing the research? If you let us in from the beginning, we can help you retain your focus and tell you about our experiences. This helps everybody. You find out what patients want, and we learn about what you are working on. This is a big plus for everyone. If we know that what you are doing, we can use it to give hope to people who are living through bad situations. Sometimes just knowing that somebody is working on it gives patients hope. If we are engaged from the beginning, we can write letters to help you get funding. We can also help develop the research question. We can provide input to help guide the research team by telling them what we need from the project. While working on the Ottawa Stroke Project, the patient partners involved told them what we thought about their approach. Sometimes we didn't always agree, but open dialogue is always beneficial. Most of us read previously published documents and decided if they were relevant to our project and if there was information that was useful to us. We also reviewed our document before it was published. When our document was rejected, we encouraged our researchers to continue working on the document, and every time there was a revision made, we took a look at it and made suggestions on how we could get it published. This can only work if you include patient partners. Working with iNeuron, working with iNeuron has been a real experience. Dr. Carol Shermans is the lead, and I'm quoting her. Our team aims to directly convert brain cells not lost to the diseases, such as resident glial cells. Example is astrocytes, into healthy neurons. What a fantastic project. Who knew? This is like something out of science fiction, but there is a whole team of researchers working on this. So what do I bring to the table? I tell them about my experiences, and I learn an amazing amount about their research. Over dinner, we talk about outcomes and learn about their successes and frustrations. And when the frustrations start to boil over, we encourage them to keep working and sometimes make suggestions on how things might work a little better. The first conference we had, everyone was a little shy, but there was still communication. By the second in-person conference, we were a team. The scientists have learned to talk to us as equals, and we have taken their information into the public sphere in words that anyone can understand. Everybody wins. So that's why I like it. That's why I do this. Let's make things better for patients and let's be focused on them. And everybody's going to benefit.
Thanks, Susan. So now we're going to open up to questions. Thank you so much, Susan. That was really great. If anyone has any questions for Susan or for anything that we've already covered so far, feel free to unmute yourself and put your hand up or put something in the chat.
Hi, my name is Nancy. I'd like to make a comment.
Yeah,
Okay.
go for it.
Thank you, Susan. I can relate to a lot of what you've said. I'm on the Family Advisory Council at the Royal Ottawa, and I've been kind of a volunteer advocate for education and more recently for mental health, also because of my family connection to this. One thing I would say that it does get confusing is the terminology, because when people initially see family when it comes to medical care, there's a lot of assumptions that, well, I'm not a family, I'm just a friend, so I'm not allowed access to the person, you know. Families can be born or chosen. And
Yes.
a lot of families get, in a way, kind of left behind. And I've certainly noticed my son also has a lot of physical medical type issues. And when you get to the overlap of mental health and physical health, it becomes incredibly complicated. I certainly didn't have as much trouble getting information and coordinating with doctors and long-term care for my mom and my aunt as I do for my son. And families also advocate for patients. We're not just advocating for ourselves as caregivers, because we're speaking on behalf of the patients who for any number of reasons, aren't able to advocate for themselves. So it's a very tricky situation. And I think this is all very interesting. I've also been involved with reviewing research type grants and things. And as others have said, when we're involved right from the beginning, it's like things sound great. If you're working from the top down, it's one direction, but when you're working from the bottom up at the same time, hopefully you can meet in the middle and make things work for everybody's benefit. Families can also be very important in recruiting and retaining people involved in research studies, because it's not easy. It's a lot of time and effort and physical effort and sometimes money. So it's just silly to me that families aren't more involved automatically. And as you said, we're not stupid. We're not doctors. We know we're not doctors, but we want to learn and we want to be heard as well for everybody's benefit. So this is terrific. Thank you.
You're welcome.
And I'm lousy with technology, so that's another impediment. It's almost like ageism now. in everything. Because if you didn't learn computers and all this tech stuff in school, like I'm lost. I'm a volunteer. I have my own devices. I work from home. I don't have IT support to help me when Teams or Zoom or anything glitches. And Teams is a lot more hard. It's a lot harder when you don't have an institutional account. Sorry, that's just a little vent.
I hear you.
Yeah, you brought up a lot of good points. Like I mentioned, patient engagement requires creativity. And so you mentioned a lot of things about barriers in terms of time. And we'll probably mention it at the end, but compensating your patient partners is also a great thing that you should do in budgeting in your grant. We can provide some resources to help researchers do that. And also, I completely agree. Lots of patient engagement involves technology. And Susan mentioned earlier that having in-person engagement can be really beneficial as well. So yeah, research teams just keeping in mind being that IT support if needed to help kind of be creative in terms of the engagement processes that you have for your team. Thanks for sharing. I appreciate the vet, Nancy. Stuart, do you have anything to add?
I was just going to say there's a question and comment in the chat from Sally. Do you want me to read it out or?
Yes, I know I saw Rebecca's hand up was to, Rebecca, do you want to ask your question and then we'll jump to Sally?
Oh, I just mostly had a comment of gratitude and to say thank you, Susan, for what you shared. I know it's not easy when you look back to those moments where, you know, your loved one has had the stroke and then the whole experience around the death. Those aren't easy moments to talk about. So first of all, I wanted to just say thank you for that. And then I think you brought something else up in terms of the correspondence and the reading of the files and the wisdom that you have to share and that you are intelligent and that everybody, no matter what grade we have or background, like that time to be part of the process. And I think time might be the factor, right, for people not to take the time to read the files. And I think it's not probably because they don't want to. I think there's so many multiple demands. And I think what this research is showing is, well, if there's only so much time in the day, where do we spend that time and what's really important? And I think what you brought up is reading that file and knowing the wishes of someone dying. Well, that's time well spent to get to know those wishes. So I just wanted to say thank you. Thank you for your involvement and what you're sharing and how you're participating and how you're advocating. I just think it's really, really meaningful. So just wanted to say a huge thank you.
Thank you. Very kind word.
Do you want me to read the question from the chat, Alicia?
Sure.
So this is from Sally, and she says, "Thanks, Susan. One of my worries is that we overburden patient partners and they feel they can't say no to things. What do you think is a good way for us to ensure that we don't make our patient partners feel they can, or make sure they feel they can say no if they wish?"
The best way to do that is just to ask them. I'm a person that enjoys research and I love learning about what's happening in the scientific world. Other patient partners that were on my stroke project, they were not as interested. So some of them, they didn't fall by the wayside, but they just didn't go back and redact some of the full documents. They did the they did the first part, I can't think of the word. Anyway, but when it came to doing full documents, they weren't into doing it. And Dr. Manjo, I said his name wrong.
That's okay.
He made it clear to us that if we didn't want to do the extra stuff, it was okay. And that was good. So if you just ask them, then they'll tell you. And also, when you go on to a project from the beginning, you know it's going to take time out of your day. And if you don't feel you have the time, then you should speak up and just say, I can't do this. Most researchers are patient and understanding in that kind of way.
Thanks for that. Yeah, just creating a safe space for patient partners to also feel comfortable letting you know as well. Stuart, you had your hand up?
Oh, I was just going to add that, one of the things we regularly discuss with researchers and patient partners when we're sort of making those initial inquiries, when someone's saying, I'm looking for a patient partner, and we potentially have someone who's interested, is we have a joint conversation. We try and have those initial discussions early, as Susan said, what do we think might be the time commitment? Where is the interest? And it's a bit of a negotiation, a bit of a discussion of like, where does a patient partner feel most interested, most comfortable? Whereas researchers, what can you offer in terms of support and those sorts of things? And it's a bit of a back and forth in the discussion, but we do try and suggest that, if possible, create a sort of document or a terms of reference or some sort of file that can be a bit of a living document where it notes down what we've all agreed to, what we all have the expectations, what does the research team commit to doing to supporting the patient partners and everything else, all those sorts of things. And again, everyone then has that as a resource. And I think the biggest thing is that everybody has clear expectations and shared expectations, and that communication piece is really important. So there's not any miscommunication or misalignment of what people think will or will not happen.
Stuart, I know we're at 1:40. Should we save all the questions and hands for the end, or should we keep answering questions?
I think we can keep going with the questions.
Okay. Nancy, would you like to go first?
Thank you. One of the things that I've noticed in research grant proposals is one, I had to laugh out loud. In their budget, they had put $5 for parking. And I thought, where the hell in Ottawa can you park for $5? Little things like that. And also, I'm wondering if there would be some way for, like CHEO has I think it used to be called Ronald McDonald House. If you want to expand the area where you're trying to recruit patients from, would there be a way for whoever, U of O, whoever's in charge, to create some kind of partnership with local hotels closest to the different institutions to give a really good break or pick up the price for a room for people who need to stay over, especially like in winter or for early appointments or long appointments? Because like I know even people from Smiths Falls area who were kind of interested in stuff, but then they just said, it's just too much. I don't know what the weather will be. I might be tired. I might not have slept well because I'll be nervous. Just little things like that, which will cost money, but I think it might be worthwhile expanding the geographic area that you can recruit people from. And also within town, just offer a taxi chit to pick people up and take them to the correct door of wherever they're going, because navigating traffic and parking and OC and all of those things are just like another layer of stress for people. And I don't know how much it would cost for like an Uber or something like that, but those are the little things that I think kind of make or break a lot of people when it comes to participating in things. And just because, as Susan or somebody else was saying, what would make things, what can we do to make it better? I'll throw it back to you two. What would make your jobs easier? What are the little things that get in your way every day to make your jobs easier?
First off, wanted to say thank you for sharing all that. And those are questions that we often ask researchers to think about. In terms of what would make my job easier, I think just having a plan. We often get researchers that come in asking for patient partners, but they haven't really thought it through. Like, what is the role that you want patient partners to play, and who are the individuals that you want to reach out to? And you make great points. Like, if you want more representation of people not just living close to the hospitals, but people that may be living a little bit farther and still accessing health services, what are the supports that they need to kind of be part of the research project? So yeah, thank you for sharing. Stuart, do you have anything to add?
No, I just think it's a great point. I'm just putting a couple of resources in the chat because, as you say, it's a big issue. It's one where Alicia and I actually face a lot of questions and looking for guidance. So there are resources. I think again, a lot of this comes back to thinking about this at an early stage, and making sure we get that input about asking that question, what can we do to help make this feasible for you? And really just, I think Alicia hit it on the head, being intentional with this, not just sort of saying, oh, I need a patient partner. That's it. It's sort of thinking through what are the questions I need to ask? What do I need to think about? And hopefully we can provide some guidance around some of these pieces.
I see a question from Rebecca in the chat that you've also been answering. Do patients contribute to authored peer-reviewed papers or receive authorship if a resource is co-created, or are they cited in a paper? And Stuart has provided some resources, and like we've kind of been mentioning kind of throughout the presentation, is just have a conversation with your patient partner, making sure that they feel comfortable putting their name on a peer-reviewed paper, because when you search up their names, they will be attached to it. So just making sure that they feel comfortable being linked as a patient partner to the project, because some patient partners may not want to be open about a health condition. So making sure that you're aware of that. And also if they have the capacity or are interested in being a co-author on a peer-reviewed paper as well. And there's lots of different resources you can share with them about what the authorship process is. And you can also do lots of different things, like Susan mentioned, having sections rather than the whole manuscript that they review, or having specific questions for them to kind of comment on when they're helping with the editing of the paper as well. Stuart, do you have anything else to add?
I've put mine in the chat, but I mean, Susan, you were a co-author on our papers, so I don't know if you want to say a few words on that.
Yes, I really enjoyed working on that paper. I learned an amazing amount about stroke, more than I ever thought I would ever learn. And I had a wonderful experience. I found many friends through doing it. And yes, it took some time. And we were lucky because most of the meetings were online, because I live south of Charlotte Lake, which is in no man's land. And it was easy for me because I didn't have to drive into Ottawa, but it was very rewarding. Um, I'm just sorry that it took so long for it to get published. It kept coming back. It was like the Energizer Bunny. But in the end, it did get published, and I'm proud of the work I did on the project. And I met you,
Yeah.
Dr. Nichols.
No, and I have to say, again, you mentioned this in your chat, but for us, and other researchers, we get a bit demoralized when something gets. So I'll give you a little bit of backstory. I was going to cover it later. So we'd had an inquiry. Someone actually approached us and said, we'd be really interested in this work and reading about it. So we did all this work. We drafted the paper. We wrote it together, and then they rejected it, and they'd approached us to write it. So we were really a bit demoralized, but Susan and the rest of the patient partners convinced us, keep going, we'll find another avenue, and we actually published it somewhere else as a book chapter in the end.
Yeah, thank you both for sharing. And I see Don also posted a short video, co-creative patient partners, about authorship as well. Before we move on, does anyone else have any more questions? We will have more Q&A after the session as well. Okay, we'll keep on going. We're gonna skip the break that we had planned, but that's okay. We don't have too many slides after. Andrew, could you set up the next poll? So we're just curious if anyone's been a patient partner or is a research team who has engaged patient partners in research. We'll just wait a bit. I'm surprisingly seeing a lot of no's. So I'm glad that people have come to this session. Okay, maybe I'll end it. I'm just sharing results. So we have one yes and the rest are no's. But hopefully we will be able to combat some of those fears or apprehensions for engaging with patients. So I'm going to pass it to Stuart to do the next section.
Right. Yeah, so thank you. And we've kind of alluded to some of the points as we've talked, but earlier Alicia talked to the benefits of having more than one patient partner for various reasons, including, and again, Susan alluded to this, is, your patient partners will often come to this with living or lived experience of a health condition and may need to step back at some point. They may not want to be involved in everything. They may not be able to be involved in everything. So again, I think having those conversations is really important. And this is a little bit of a framework you can use to help with those conversations. So this is a very simple schematic, but it sort of has this spectrum of the level of involvement that you can use to help have those conversations. So on the far right, you'll see this is there's a role called lead support, where it's very much where the patient partners are leading the project, co-leading, and we have this where there are co-principal investigators on grants now. Alicia talked about this being the funding requirements. You actually have co-principal investigators. Dawn's actually a co-principal investigator on a number of projects, along with other patient partners and researchers. So we have a real mix of different partners. You can have collaborate, so a slightly different role where maybe not leadership, but working on a regular basis with the team. But you may also have other roles where people are consulted, they're asked to provide feedback, but they don't necessarily have decision making of how that information is used. And maybe it's a different role. And while we wouldn't necessarily say that being told about research is really patient engagement, you can build that in as part of your mechanisms for that communication that we talked about. So maybe you have a newsletter so that for those patient partners who are not involved in a particular step, they're still kept up to date. They don't feel like they're being left out of the project. So again, you can have you don't have to just pick one of these. You can have different elements of this level of engagement for your different patient partners. And again, some patient partners may be involved in some parts, some may be involved to a greater extent. So again, this is a tool you can use to help with those conversations early on. Next slide, please, Alicia. And these are some just concrete examples of things you can do. And we've kind of simplified the process. So we can think about pre-project, during the project, and then after the project. So these are just some simple things you could do. So there are things like lab tours where maybe there's a way to open up the world of preclinical research to those who maybe are not as familiar, and that might be a way of sort of showcasing this and generating more awareness. It can also be part of a broader engagement strategy where, you know, it gives more context to some of the things that you're talking about with your patient partners. I'll give a concrete example of identifying research priorities and questions in a minute, but that's certainly one area where, you know, if you want to make sure that we bridge those translational pathways from preclinical to clinical to implementation and uptake in care, then we need to make sure that if we're wanting to improve care, that line is traced all the way back to the start, because if we start off on the wrong pathway, we're going to end up miles away from where we want to finish. So again, engaging early on can be really important, setting those research priorities and questions. And there are structured ways to do this, such as the James Lind Alliance. I don't have time to go through it now, but I can share those resources. But also within your grant itself, a key part when you're working with patient partners can be having those letters of support. Why is this research important? How are your patient partners shaping your research or will shape your research? Very quick example where I had colleagues who were working in cancer, and I'm going to completely butcher the details of the work, so I apologize to the research team. But in essence, it was developing a new mechanism or pathway so that they could target chemotherapy to where tumor cells are. So that if, say, a surgery has taken place and there's this treatment after surgery, it would get basically attack the rest of the tumor if it wasn't all excised from the surgery. And the patient partners, you could see how important this was to them. And it wasn't just the treatment for the physical. What came out of the conversation was, as a patient and as a family member, caregiver, the anxiety of worrying whether all the tumor had been taken out was such a huge piece. And having this treatment potentially that would mean it doesn't matter if the cells have migrated to somewhere else, the chemotherapy is going to find them and target them. That was a huge extra benefit. So again, it brought a different understanding of why this was important, but also the other ways that this would be important. And again, bridges that physical and mental piece. So that was something that was put into a letter of support that really helped make the case from the patient-oriented research perspective. Again, during the project, and we can give an example in a minute about feedback on the materials. Susan's experience with the stroke review is one particular area where we had a lot of discussion, not only in terms of what we could do within the review, but just gaps for future research. And just one example was part of the discussions we were having. I think it was limb spasticity was a big issue that came up that was really important. And it turned out we don't have good animal models for modeling that. So it was a huge gap if you think about that piece of like what's important to patients, and then being able to do preclinical research to start to address that is like, how do we do this in preclinical animal research? We know it's important, but we can't actually do it very well. So it pointed to other areas as well. And then interpretation of results, again, understanding sort of, well, what does this mean from your perspective? You know, help us understand, this is what we see. Is this what you're seeing? How would this impact you? How would change to this impact you? Those sorts of things. And then finally, we've already talked about some of the post-project work, but obviously contributing to writing and reviewing of manuscripts. We've talked about that again in Susan's work, and I put some links in the chat. Lay summaries, again, finding different ways to get your message out there, not just in an academic journal. Are there other ways to share your research? And then finally, co-presenting, taking part in a conference, present like this with Susan, presenting together. Again, there are things that come with that in terms of preparation, support, have a colleague who's co-presenting at a conference, they not only do they not have IT support, there's no admin to book travel, book conference fees. It's not, you can't expect patient partners to register everything and do all that on their credit card and then wait 6 months for reimbursement. So again, finding ways where we can support that, maybe take that administration on, take that funding on, and again, facilitate engagement and involvement. Next slide, please. So I mentioned I'll talk about a couple of examples. I know we're at time almost, so I'll very briefly go through these, but I do want to say that the Lab Partners website that I'll mention later does have a number of examples on it. So this was an example where Dr. Weinstein was interested in this rare pediatric disease called glycogen storage disorder. Basically doesn't break down the sugars, very focused on treatments, particular types of how do we identify those treatments, and then talking to parents of children. So one of the biggest things that keeps us up is like, how do we do this when our child's asleep? If these are fast acting treatments, how do we have to wake them up? It's a real anxiety piece. So that really oriented his research to try and find this slow release treatment that could mean the children can sleep overnight. The parents didn't have to get up and those sorts of things. So again, an example of a real world case where this has really been life-changing for many parents and families. Next slide, please. Thank you. So this is the work that Susan was involved in, one of the projects that Susan was involved in. And again, you can see here that we engaged with the patient partners, and there were multiple patient partners. I can't remember whether it was 8 patient partners on this project, who really helped set the priorities. We had discussions about which areas of stroke were particular interest. Again, we found out that there were gaps where we said, well, maybe we can't look at that. So again, part of the conversation was, where are the limits of what we can and can't do? But Susan, I don't know if there's anything else you want to talk about this particular project or the work that we did.
Well, we focused on ischemic strokes as opposed to hemorrhagic, which Ron had a hemorrhagic. But I mean, the researchers were really good at explaining what it was that they were going to do, and had an amazing array of examples that we could look at, and were really forthcoming about telling us what was happening in the lab. We didn't actually visit the lab, but yeah, I really enjoyed the experience. And one of the ladies that was on the project with me, Laura Stronghill, she'd had an ischemic stroke, and she was very forthcoming about telling us how it affected her. And she kept telling them that if they got this to work, she was volunteering to be the first person to get the treatment, which was great. But yeah, I worked through pretty much all of the project, and it was great. I learned so much, and like I said, it was beneficial for all of us. And it was really fun working on the final document, trying to get it published and trying to get, well, JAMA wouldn't take it, but we did eventually find somebody who was willing to do that. But yeah, we developed the question, we worked on the protocol, and did well, we had a librarian do the searches to pull up the documents for us, and we were each given, I think, 3 documents to read the extracts from, and then some fell by the wayside after the extracts, but the rest, some of us continued on reading the full documents and doing synthesis and analysis on it, and all of us participated in writing and publishing it. So yeah, everybody won. We took some of the work away from the researchers so that they didn't have to do all the administration on this. So it was beneficial for everybody.
Thank you. Alicia, if we just go to the lab partners slide, I'll just skip over the other example of sepsis. And yeah, so again, I'm conscious of time, so I don't want to sort of delay people who have to get off, but this is a website for the lab partners team. This is the team, many of whom were also behind the work that Susan's talked about. But there are lots of resources on that website. We can share the link afterwards as well. So you'll see the case studies as well as some tools and resources for actually helping support engagement at different stages of preclinical research. Next slide, please.
Where can we find help? So OPERA, the Office for Patient Engagement Research Activities, we do provide consultations for researchers and research teams interested in learning more about patient engagement and want to get feedback on their grants. And so we can work with you to help develop patient-oriented research questions and your patient engagement plan. We can write letters of support as well and provide budget tools for your grants as well. We also do outreach and education, example this session. We can also help identify patient partners, and we also do patient engagement research ourselves. And so the next slide, also just wanted to highlight our email is opera@ohri.ca. If you do have a quick question, but if you do want to receive a consultation or more thorough support, we do urge you to go to the Ottawa Methods Center request for service form and just click on engaging patients and stakeholders as partners in research, and then we will get a notification and then we can book a meeting with you to learn more about your research project. So I'm going to pass it to Don and Andrea to share a bit more about the BHI resources.
Thanks, Alicia. I guess we just wanted to leave people with also some specific BHI resources. So Andrea and I have our emails there, and we'll put them in the chat for you as well. And then we've also listed a few resources from BHI, as well as some recommended resources that we have for people. So Stuart has already put the tips for creating safe spaces link into the chat. BHI also has a compensation guidance document for patient, family, caregiver partners. So to help you out with your budgeting needs. Andrea and Christina Lewis and others did a great deal of work on what's called the casebook. And these are examples within BHI of research teams that are doing exemplary work in some of the different crosscutters at BHI. Patient engagement, co-production, knowledge mobilization are part of that casebook. And then we've got a few other, I'll just call them good resources that might help you in your work. So there's some kind of basic training in patient engagement from one of the CIHR institutes, and you'll receive certificates of completion for completing the modules. And there's some other practical resources, including the authorship video there for you too. So no problem for us to share all these links with you after the webinar today too.
We just wanted to highlight some training, patient-oriented research curriculum in child health with Porch. There's also family engagement research course, which is offered by McMaster, I think, and then CHR's Institute of Musculoskeletal Health and Arthritis course, which I think Don might have helped co-create, is always a great resource for researchers and patient partners to access. And there's also the CanStroke training resources and a whole bunch of other trainings that we probably haven't highlighted. And then we just wanted to end off by acknowledging that we have borrowed many of these slides from the lab partners group that we mentioned already. Dr. Manoj Lalu, who Susan mentioned she worked with, is the PI for the project, as well as Dawn. So we just wanted to acknowledge them. And I'll give it to Dawn to kind of end it off. But yeah, if you have any questions, feel free to raise your hand or put anything in the chat.
Yeah, I think to Alicia's point, we recognize that some folks might want to jump at we're around an hour or so. So we're really grateful that you came. And, if you need copies of anything, you can feel free to send us an email and we'll make sure that we get back to you. For those of you who would like to stick around for additional Q&A, kind of like ask the folks on the call anything, or if you've got specific patient engagement plans you might want to bounce off the panelists as well, we're happy for you to join us for the next 20 or so minutes. But just wanted to recognize that some people might only have an hour or so to be with us, and we just wanted to thank Stuart, Susan, and Alicia. And Susan, especially, you've shared really personal information with us, and just wanted to echo what Rebecca said, to thank you for sharing that. So